introduction, and thank you for having me in Virginia. Like Tiffany said, I work out of Philadelphia in a place called Kensington for Prevention Point, Philadelphia. I don't know if you are familiar with that. It's the largest open-air drug market in the U.S. So because of that, I have a lot of training that goes on just about every day. What I would normally be doing on a Friday like today is doing some outreach in the community, checking on folks to see if they're alive, and towards the end of my day, leaving Narcan stashed in bags such like this, for folks who might overdose. Being as though we have the largest open-air market in the U.S., there are people who are flooding in from all parts of the U.S. For the drugs, and what we like to do is engage everyone as much as we can in preparation for a weekend. When the normal week starts for some folks, there's an exit of staff, and because of that, I want people to know there's people that still love you. So we keep Narcan kits like this just hanging around everywhere in preparation for someone who may overdose. I've been doing this work for going on, I would say, 6 to 7 years. I started in the shelters. Just some backdrop about Prevention Point. The Public Health and Social Services is a nonprofit that works to promote health, empowerment, and safety for communities affected by drug use and poverty. Prevention Point uses a harm reduction-based approach in everything, meeting people where they are in life and helping them to get to the next place that they're going. We provide drug treatment and options where individuals are ready. In 2023 alone, participants came for nearly 3,500 visits to receive medication for opioid use disorder treatment, up from about 500 in 4 years. Prevention Point also provided emergency housing to 171 people and transitioned 56 people to permanent housing in 2023. With the help of my overdose prevention team, we were able to distribute over 100,000 doses of Narcan in last year's fiscal year. Now, what that's going to look like is training as well as distribution with the Narcan to various communities that are underserved. There are parts of Philadelphia where we are underserved in regards to harm reduction. What harm reduction looks like to me is letting people live another day. It might not be, if someone's not ready for treatment, we have other ways to keep someone alive. And what that is just provide compassion, and this is us on Kensington Avenue, right? What is harm reduction? This photo right here, me and my coworker, Sean Westfall, I credit him a lot. This is Kensington, and what we normally do is we do street-based outreach, and we check on folks to see if they're, we try to meet their needs any way we can. What that might be is someone might be in need of a pair of socks. They might need just clothing, something to drink. While we're out there, we're also responding to emergencies. What that could be is it can be any medical emergency or someone overdosed. So we're always out in the gear that we need to do this kind of work. And we do this in a team because it's high crime and where we're at. These blue bags, they consist of 2 doses of Narcan, face shield, gloves, literature in Spanish and English, and just a bag that someone could carry around their belongings. When you really think about it, if someone is responding to an emergency overdose, we want all the contents in here to be available. Harm reduction is an approach to work with individuals in high-risk behaviors. Interventions to reduce the harms of substance use sex work. We're dealing with low barrier services. We have between 60 to 65 people that stay in our shelter, and it's very low barrier. We get a lot of people off the streets, and we engage them. We have staff over there at our Beacon House that have a lot of lived experience. In this kind of field, there are not a lot of people who are running to do this kind of work. With that being said, if you're involved in this kind of work, I would encourage you, take your self-care days. Burnout is real. If I can leave you with one thing, burnout is real. Take care of yourselves and each other. I have a lot of empathy and non-judgment for folks that I service. If I'm introduced to someone, I like to know their backdrop. And what that looks like is I don't look at the individual in their addiction. I look at them to where they're going to be. Just because I know that addiction is just kind of something that we are going to go through. Addiction, I believe, has an expiration date. I don't let people dwell on, the harsh realities of life. I try to encourage them as much as I can, and I never sell anyone false hope. It's a no wrongdoer approach in harm reduction. So people walk through it willingly and often. So people to get the help they want and need. So we keep people alive. We have a drop-in center, and in my drop-in center, we get up to a few hundred people a day, and these are people who feel comfortable coming to our drop-in center because they know they're not going to get judged. Kensington has been known as the land of the lost or zombie land, but we want to change and rephrase that. There are a lot of people who come to Prevention Point for the simple fact that we're going to treat them with dignity and respect, like a human being that they are. I look at every individual as that can literally be me. That is someone's father, mother, brother, sister. So with that being said, I look at things a lot different. I look at things as everyone as an individual. Some people might get clean. Some people don't want to get clean. Are we here to bash people if they don't want to get clean? Someone might come into my drop-in center and just want a cup of coffee. I have staff there that are prepared to give their all for folks, and not look at them in a stigmatizing way. Some of these wounds that are affiliated with Xylazine use, there are people who, that's frowned upon. People think that that's disgusting. But like I said before, these are human beings, these are individuals that we're dealing with. Next slide. Why harm reduction? We try to get those who say no to say yes or maybe. We want to keep those who always say no alive. Just give them another day to live. Whether it's overdose prevention, and what that's going to look like is the average user, I want to tell them, you matter to me so much that I hope you stagger your use when you're using. There are some people who, they don't like that approach. If I tell someone, you guys have to stagger your use. If this person doesn't want to clean today, am I going to bash them so much that, that I chase them away? I'll tell someone, test your product. Know your tolerance. If someone goes to detox today at the hospital, or they go to jail, they're at a zero tolerance. I can't expect that person, if all they knew was going out there and getting high, I can't expect that person to come out and get it together right away. To some people, this might seem like I'm babying them in their addiction, but this is a long haul. And if you're in this field, you just got to know that you got to have patience. It could take longer. Some people get it a lot sooner than others. Some don't. This photo right here, this is my coworkers. We're tending to someone up there who overdosed in his wheelchair. God rest his soul. This photo down here, this is how I distribute Narcan in the community I'm at. I can't, I have a lot of people coming to the city, so this is actually a 24-hour convenience store that I stash my Narcan in places of folks who might overdose. I think ahead of the curve. I think just like the dealers are out there every day tweaking these drugs, what can we do to be ahead of the curve? One way is I do community outreach on Fridays leading into the weekends, because I factor in there's a lot of kids who are off of school, and I don't want them to see someone overdose and there's no Narcan around to save someone's life. If I do this just about every day, I build, I'm consistent. What happens is I have people who might have not been as confident. Now I just built them up because I'm dealing with people who I've never met before. This Narcan, I may never personally save them, but I'm leaving it for the next person. And somewhere in the world, their families are probably gonna be thankful. This photo here, this is Tracy McCann. Tracy came to me about 3 years ago. looking for a boyfriend. Outside of the work I do, I like to find missing people in Kensington and reunite them with their families, anywhere in the U.S. We have some funding in Philadelphia where I can put someone on the Greyhound and get them anywhere in the U.S. And Tracy came to me looking for a boyfriend, still a little bit active in her addiction, and she fell deep into addiction, so now I had a double save I had to do. Since then, we got her into treatment, and she's now living in St. Louis doing this kind of work we're doing. You can see from the heavy Zolzine use the wounds that were affiliated with that. Almost took her arms out. This is her in her active addiction. This is some of our wound care team right here. We have mobile wound care, and we also have wound care at our building. We have that 4 days a week. If you guys aren't seeing Zolzine use here, great. I pray to God it never comes up here, because one of the main factors of Zolzine use is the wounds that are associated with it. It gets people to lose confidence in themselves and therefore kind of hide out in their addiction. I seek those people out. I like dealing with the population of people I deal with because they're the most vulnerable. I advocate for them. I try to lift them up as much as I can. This is Brooke, God rest her soul. She had, a lot of wounds associated with Zolzine use. And this is the streets that I work on, And I know this is a university, and we're dealing with collegiate recovery. I pray that it never gets to where they're making their way down here. So this is awesome what you guys are doing here in regards to having everything kind of like a community where folks are going to universities, and before they get to this point, you guys are engaging them. I think that's a wonderful thing. I know Susie's going to come on later, and you guys are dealing with other universities. This is awesome work. There is a recovery for RAMs in Philadelphia, Jefferson University at 2 locations. I've done a lot of work with them. Next slide, please. Harm reduction is meeting people where they are. These are literally tents underneath one of our this Emerald Street Bridge. Since then, this has been cleaned up because there's new development in Kensington, so they kind of dispersed a lot of these folks, and they sent them on their way. They're sent them to various parts of Philadelphia. Kensington is kind of like the stomping ground for this work. So what we're trying to do is educate folks in different zip codes in Philadelphia. Just like I'm here, I'm trying to do the same thing in my own city. But unfortunately, there are some people who think that addiction kind of has borders. Substance use has borders. And we are reaching other diverse populations because we want to let people know your crack is tainted, your powder's tainted, your pressed pills are tainted. It's not only a certain population of people who are just using substances via syringe. And it's hard to push this kind of work when you're dealing with a society who just solely thinks that folks are dying just from syringe use. It's hard, but I believe if you stay consistent in this kind of work, you can put the message through. We house a lot of these folks. We engage a lot of these folks. Now, what that's going to look like is if I just walk around with life-saving devices and there's a woman who needs a pair of socks because she's been trafficked, or there's someone who hasn't had a drink in days, if I just bring out my life-saving devices, I'm doing an injustice to another human being. So what we like to do is we walk around with wound care kits. We walk around with snacks, whatever one may need. If I want to win them over, I might have to take a different approach. And these approaches, sometimes they're not even taught. Sometimes it's just indebted in you. You know what I mean? There are people now who, they take people's carts. So we've developed, with our Philadelphia, there's a harm reduction organization called the Everywhere Project. They developed these small Amazon containers where people can put their stuff in there. Every way that we're going to get resistance, we have to fight back. That's what I'm trying to say. We try to get people off the streets. We have a catch van that comes and picks up to 14 people at the end of every business day and takes them to one of 2 shelters. And while that's going on, that temporary Band-Aid for someone to stay in the shelter overnight, we try to work on them the very next day. How can I put you in something more permanent? How can I refer you to something? Next. Harm reduction creates spaces for people in the stages of change. Now, relapse, fall back into old patterns of behavior. Maintenance, sustained change, new behavior replaces old. Sometimes I try to plant seeds in folks, and what that might look like is I don't push for them. I don't push for recovery. I just push for them just another day. Let me just have one more day with you. And every day what happens is with the empathy and compassion and consistency, they see that I'm solid, that I'm right there with them. I walk alongside with them. When I'm doing my outreach in the community, and there may be 30, 40 people actively using, I'm not gonna walk away from them. I'm gonna walk with them. I like to hold up these things of Narcan up when I'm going, because this is a sign of relief anywhere in the world, if I have my Narcan up like this. So while people are chanting whatever drugs are out there, dope powder hard, I'm not saying a word. What people are thinking is, this guy doesn't even know me, and he's out here Monday through Friday. And what church you go to? No church. Who's he affiliated? No, we're just going back to being human again. I just want to change the culture. I realize that some people are so caught up in themselves where let them handle their own thing. It's not their problem. But if you just consider the fact that that is someone's daughter, mother, brother, that can literally be any one of us, it changes your perspective a little bit. Every day I'm humbled by the work I do. Met some awesome people in this process. Next. New registrants are 5 times more likely to enter drug treatment with harm reduction. New syringe services program registrants are 3 times more likely to report reducing or discontinuing injection as those who have never used an SSP. Here's what that looks like. We have a table dedicated to harm reduction and overdose prevention services while our syringe service department is giving out syringes. What I usually get from the feedback from active users is, hey, Carlos, this batch over there, it's making me do this. This is doing this. So with that syringe service, what happens is we're opening up the doors for people to be distributed syringes. I know that's frowned upon, but that's where my feedback comes in, because people see that I'm out there in the community every day. I know you're using syringes, but I'm just here as an open ear just to hear from the horse's mouth what's really going on. So if you take syringe services away, you'll never get that connection. People who work with a nurse at an SSP or other community-based venue more likely to access primary care than those who don't. Those nurses have so much compassion. There's times when people look the other way when someone has these wounds. They don't give them the time of day. So what happens? These folks are in rural areas trying to stay away from the mass population of people because they know they're going to be judged. Our nurses give some of the most care. So I encourage you, if you have to utilize wound care in your facilities or in your communities, that's a lot of work. That's a daunting task on nurse or volunteers or whoever may be using, providing that wound care. These people have some of the most respect I've ever met for individuals who are coming there, sitting down with them half hour, tending to their wounds. Not a lot of people, like I said, are running into this field to do this kind of work. So the ones that are here, we have to look out for each other. We really do. Because a lot of us have lived experience, and if we take one of you guys away, there's no one there to replace you, essentially. Next slide. With Syringe Services Program, look at all the connections. Homeless outreach, housing case management, drop-in center, overdose prevention, someone getting out of jail, reentry pad, case management, TALC, HCV care, MOUD, and we have this in various parts of the city. What we do is we don't limit ourselves to just Kensington. We go in, our data shows if there's a spike in overdoses, we might have 12 targeted zip codes, and we try to have our MOUD van for 6 months at the worst places. Now, what that's going to look like is, if you could just listen to me on this, there are parts of Philadelphia who don't have the knowledge on how to deal with addiction. So what we do for 6 months, we post up at a location, and we give all of these resources: case management, treatment, MAT treatment, Suboxone, Vivitrol, and then 6 months later, we go to another place. So there are parts of the city where they're not getting this. And I encourage you guys, same thing. Don't only focus on like your direct, who you're dealing with, because there's someone else who needs this kind of education, and they can benefit from it. It's a domino effect. You might train an organization, and they may tell someone else about you. It's a good thing. STI, PrEP, mobile clinics, wound care, and we have our respite housing, which we have about 65 folks at any given time who are in a permanent shelter on their way to housing. Next slide. These are some of the numbers. I'm just going to go over a few numbers. Overdose prevention trainings, 1,300. We train universities, various organizations. This Sunday, I'm going to do a community fair in Chester, PA. The woman just called me a few minutes ago. She said it is the need of this training because there are recovery houses out there who folks are dying of overdose, and we deal with a vulnerable population. We deal with a population who no one can advocate for them. So it's almost like someone can just, it's easy money, work with the population of people we serve because nobody's really paying attention. 16,902 free meals. We have one of the only outdoor public restrooms, and we've saved a lot of lives. I think someone being able to use the bathroom and eat is essential. So we try to knock out those two things. We give out free IDs, 516 prescriptions for PrEP. We have a lot of volunteers. The work we do, we have a lot of students that come down and they want to volunteer and kind of see what we do. We do real-life world trainings. These are all our drug treatments right here. MOUD, drug and alcohol level of care assessment and referral to treatment. Free Narcan distribution and training. Free test strips. We have xylazine test strips. And we put these in kits. The reason why we put these in kits are there are some people who are coming from different parts of Philadelphia, family members looking for their loved ones who have someone who is actively using. And they need more than just a good hope talk, because there's a good chance that their loved ones, when they come back to them, hey, what's your backup plan? Should your loved one overdose in the comfort of your own home? So we put these kits together. We have 383 placements to emergency housing and drug treatment. Community engagement. A lot of our staff live in Kensington. What I do, I have a new initiative. I'm the community relations coordinator as well. What I do is the same folks that they talk a lot of schmack about that use these syringes, they help pick them up with me. I put a vest on a homeless person, and we're out there picking up in front of people's schools, churches. And another initiative I have is we feed 75 poverty-stricken families in or around the community where I serve to kind of smooth it out with them. We want to be able to still coexist, a harm reduction organization in this community. We get a lot of pushback, but you can't stop the fight. If you eliminate harm reduction, you'll see a drastic fall. Next slide. This is kind of like one of our mobile vans. We used to have this van. Now it's in a different part of the city. And what this looks like is we might have syringes being given out, test strips, Narcan trainings on the spot, food, maybe a wound care nurse there, maybe just wound care supplies. Something like this is necessary if you can't get like an actual building in certain parts of your city. Something mobile would be awesome, a few days a week. You can use a harm reduction approach in medical care, housing, social work, and recovery. Flexibility, providing care for our most difficult patients. Frequent flyers. What a frequent flyer to me is someone who comes in every day. Someone comes in every day. Someone who might have lost his mother, and wife in the same car crash. How can I tell that person to stop using? I almost resonate with that individual. It will probably put me on the brink of using. In a harm reduction model, the most difficult patients are those most at risk for overdose. Harm reduction approach and setting make space for those who might not be welcome in other clinics or housing, for the simple fact that they get stigmatized the moment they leave. So sometimes the best version of themselves is when they're around you. So don't change your ways when it comes to harm reduction. You know, there's a lot of policies with folks in addiction, but you have compassion. That's all I'm gonna say. Have compassion. Next slide. We can be a part of reinstating what our society has not to people in difficult situations. Thank you for your time. Any questions? Any questions?
So if we could, we want to, just one question really
Yes.
quick.
Okay, our funding sources, we are funded from the state. We are, we have various donors. That's all I can say. We have, yes, public and private. We have some grants, and there's a grant that I am now a part of. It's called the NACHO grant, and what this does is we target 11 to 12 high-risk zip codes, and myself and my coworker Scout, we do outreach in these communities and for our research department. What we're trying to do now is get the lingo and the language of folks in addiction in different parts of the city. This way we can better manage them. If someone's going to a hospital, I want those doctors and nurses to know what some of the language is. This way we can better serve them. That's a grant that I'm a part of now.
All right, so to start off, I would like to have each one of the panelists introduce themselves, starting with Susie.
Well, thanks everybody for staying to the end here. This has been a great event, and thank you for the invitation to be here. I'm Susie Mullins. I'm the program director for the West Virginia Collegiate Recovery Network. We're funded through the state opioid response funds, and similar to Tom, we work with 9 schools that are in the southern part of West Virginia. So we'll be talking more about our harm reduction efforts.
Thank you, Susie. Adam?
Hi, I am Adam Hess. I work with Virginia Department of Health, specifically in the Hampton and Peninsula Health Districts. We are part of a new opioid response and harm reduction program we call Project LEAD. We started that back in February of 2023, so it's new. There's been a lot of innovation to our work, and hopefully I get a chance to share that with you today.
Thank you. Edward? And
Good
again, I
evening.
apologize for mispronouncing your name.
It's all right, it's all right. I'm Edward Peters. I'm with the Health Brigade, formerly known as the Fan-Free Clinic. I am a IDU, outreach specialist, meaning that my population are individuals that inject drugs and their partners. I do HIV testing, hepatitis C testing, and we also do referrals. I'm with the best team there is, our team.
Thank you. And we've met Carlos, but Carlos, anything else you'd like to add?
My name is Carlos Del Valle. I work at a prevention point in Philadelphia. I also help co-coordinate Men's Night every Thursday, in which we, for 3 hours on a Thursday, we give folks another chance of life. We give them a safe environment just to get off the streets and all the Kensington woes, get them off for about 3 hours. We give them wound care, haircuts if available, showers for the men, clothing. We give them the time of day, and if someone needs to get the treatment the next day, if they need to get tested, whatever it is, during that 3-block period of time, we're planting seeds. I also help oversee our NACHO grant, which is we're targeting 11 to 12 zip codes in Philadelphia that are underserved in regards to overdose prevention and harm reduction, and we educate these communities, and we want them to know what could potentially be ahead of them. This spreads like a wildfire, and we just want to be ahead of the game. I also am a coordinator of the community relations department, in which I try to have my community and a harm reduction organization like us coexist. So I have my volunteers are folks in homelessness who are literally picking syringes up with me, making Kensington a better place. I give out 75 bags of groceries to poverty-stricken families in and around my area, to include crossing guards. We need to be aware of the government officials and employees that are in the area, and we need to be aware of the kids in the area. So we try to educate people as much as we can, as well as, we're ran in Kensington.
Thank you all. So I'm going to ask them a series of questions, and I will be sure to leave some time for questions from you all. So the first question, what are some of the challenges you faced or have faced while working in harm reduction? Adam, you want to start?
Sure. Put me on the spot. I'll start. So we're opening our program, which is a new program in our location, and we serve almost 500,000 people, which means that we have people from various backgrounds with different biases and perceptions as to what is harm reduction work. And so one of the biggest challenges that we faced with our program is really getting the education out as to what harm reduction is and what it does versus what they thought of harm reduction and what they think it does. And so the way that we approach that and the way that we've worked that so far is we really need to build trust with everyone in our community, not just with people who use drugs, not just with local officials or particular residents in certain areas. They need to be able to trust us, the work that we're doing, so that we're able to share the data and educate and give them a clear picture of harm reduction and the benefits that it is for all of us in that location.
And Susie, you're in a collegiate setting, so do you face some of the same difficulties?
We have been really fortunate that we haven't had quite the barriers that maybe are in the general population or general community, mainly because of the relationships. And with the way that I work for Marshall University Center of Excellence for Recovery, and we are also part of a consortium of schools in the southern part of the state. The presidents of those schools came together to create this coalition, and so we've had presidential level support from the beginning. So we've been able to get naloxone on campus. We now have fentanyl testing strips. We'll be launching our xylazine testing strips. We've gotten another grant from Bureau for Public Health, and so we've been doing a lot of hepatitis testing and treatment in the last several months. So it's been really quite amazing that we have not had the resistance. One of the things that we did was we started off from a positive standpoint in terms of, I'm sure everyone has heard about how devastated the southern part of West Virginia has been by this protracted 20-plus year epidemic. So there's nobody that is untouched in our state. So I think that gives us a different level of understanding and compassion of what we need to be doing and the impact and all the things that we thought or preconceived notions that some folks might have had. Those are things that have had to be challenged because now this is everybody's brother. This is everybody's, persons that they go to church with, every people in their communities. So having that level of support from the presidents, we have one of our presidents who does Narcan training, goes out and does it in the community herself. So that's really inspiring. And our team is, I agree with you, we've got one of the greatest teams. Our peer support specialists are the staff that take care of all of this and do all of the training. I'm the behind-the-scenes person that takes care of administrative things and works on things at a different perspective. But they're the ones that are out on the ground and training fraternities and sororities and tabling, and with this week being Collegiate Recovery Week, doing lots and lots of activities on all of our campuses this week. So we've been very fortunate. There are challenges, but we've taken, I think, advantage of the things that could have been challenging and made a lot of progress in a short period of time.
Thank you. Edward?
Yes, it's been a challenge for us. I've been doing this work since 2003. During the time, there was not in the needle exchange programs. If you got caught with a needle, that was because of drug paraphernalia, you was going to jail. People that was overdosed was either dropped off from a hospital, rolled up in a rug, dumped in a super can or something like that. Because of the laws at that time, possession of narcotics was considered a 5 to 40 year bit for heroin. So a lot of times people who had charges didn't touch anybody. And so we started gradually getting to that. We had some people now that came out with us in the field who had syringes. It was a group of hippies that came with us out there in some of the subsidized housing areas. Now, for me, I'm a convicted felon, right? So I couldn't be around any guns, drugs, bullets, or anything. So that was a challenge for me to do the kind of work in the subsidized housing areas. That had to be overcome. Over a period of time, our program started growing. Some laws were changed, and we were able to go out there and help some people. I heard you talk about the kids, right? Some of the things that I encountered were kids who did not have clothes and food and stuff like that. So the people that work with me, we bought a lot of tennis shoes and stuff like that to help them to go to school so they would not get teased and stuff like that. Then we also started seeing the young drug dealers out there controlling things, coming to head of the household. So we had to deal with all of that as a collective unit, deal with other agencies to help them also. And then finally, a law passed, we was able to get some Narcan, stuff like that, and start helping some people. People that was real vulnerable who didn't know anything about it. Now, when we first opened up, nobody black came to our agency at all. It was a setup. That's what they thought, it was a setup. So they didn't come at all. It was only Caucasian people who came to get some help. Finally, we moved from our office into the streets, some of the subsidized housing areas, that's what they call them, subsidized housing areas. Totally black people projects, right? So we was able to go over there and help some people finally.
Thank you. Carlos?
Some of the challenges that I faced and still am facing, in our drug supply in Philadelphia, just about every substance is tainted. You have some communities who, if you look at the numbers last year, you might have had 19 African-American people who died in a certain part of the city. So when I enter their zip code, they tell me, Carlos, nobody uses syringes out here. Bring that stuff back to Kensington. But education comes when I let them know, hey, your pills are pressed. It's hard for them to grasp that because folks are just solely thinking that it's just from syringe use. What do you think the dealers are doing every day? They're tweaking it because they see a certain population of people are getting clean from harm reduction organizations via MAT treatment, whatever way it is. So they're targeting other populations of people in ways that they never did before. Your Xanax is pressed. There's fentanyl in your perks. So it was a hard time to persuade certain people, but we stood at it. If I would have buckled when I first started seeing this resistance, it'd be a lot of more lives lost. But now you have churches who are now saying, we need that training. Before, we were getting a lot of pushback. When I do my outreach in other communities, I'm looking for syringes on the floor. Because in the back of my head, that's what people only think people overdose from. What the xylazine use is doing is people might not be dying as a result of a xylazine overdose, but the wounds contributed to it. We like to check up on people. If I see someone might be overdosed, but they're just sedated, I can reposition them and move them so they don't cut off circulation, so their arm don't get cut off. We need people to start teaching this. We need to bring it back to being humans again. So the resistance that I had was a lot of times that this isn't needed here. Or whatever worked before, we have to devise new ways because just as there's evil and good, there's people that are changing things every day. We need to adapt to new ways and new practices. Whatever worked for back in the day with the xylazine use, sometimes those dealers are within 6 feet from them. How did I target those people? I have to be strategic how I target them. Compassion, I have to engage. I can't just offer what I have. How can I help you? I want to be a listening ear. So it's a lot of patience, with this. We got a lot of pushback, but we kept on with the fight.
Thank you. So, thinking about something you said, medication-assisted treatment, which we call medication-assisted recovery, it basically utilizes medication to help people with various substance use disorders. However, there's a thought that they are substituting one substance for another. What is your response to that?
My response to that is let them live another day. There's different ways. There's there's different ways that folks can get clean if they're going to get clean. I believe that it works. There's a lot of success. We have Sublocade now, and there might be some folks who, that's a lot of discipline. When you're dealing with folks who experience homelessness, that's a lot of discipline for them to go to methadone and some of these other things. So we develop other ways. You know, get a Sublocade shot, get a Vivitrol shot. We just try to meet them where they are and get them to where they're going next.
That's right.
Anyone else like to chime in on that?
Yeah. For me, I first drank methadone in 1993. Then I drank methadone again in 1994, 95, 96, 97. It took me a while to get there so I understand where they are. And that's my job, to wait with them until they make up their mind what they want to do, right? Look here. I can look in this room and see some people that I work with. They're clean now. It took them a while, but they finally got it. I'm allowed to assist them until they get there. If they need my help, look here. People call me all the time. Look here, we need somebody finally, they're ready. I got a number for you. If that don't work, call me again. Just keep calling. I'm available.
I'd like to just add, who are we to decide when someone's ready? You know what I mean? Somebody, it might take a little bit longer. We should not knock their approach. You know, I deal with a lot of people who I've been seeing for years down there. Sometimes it's the community. They feel better maybe coming to see us every week. You know what I mean? It's a community where they feel no judgment coming from us. So we shouldn't knock anybody if it's taking that individual a little bit longer. Put yourself in their shoes. Wouldn't you want to run into some smiling faces like you guys every day doing the work you do?
Thank you. Adam or Susie, would you like to bring in?
I liked this question.
Okay.
I like this question so much that I wrote out my answer because there's a lot to it, and we don't have a lot of time, so I won't read you the entire answer. But the question was, we repeat the question, the thought is, are we replacing one drug for another with MAT treatments? And the simple answer is, yes, we are. That's what we always respond. Yes, we definitely are. And then here's why. Let me tell you why we're changing one drug for another. First, studies show that individuals who use medication-assisted treatment in addition to therapy have better outcomes than those who engage in therapy alone. We know that Suboxone attaches to the receptors but only activates enough to suppress cravings and has a much lower euphoric effect than heroin or fentanyl. It also creates a ceiling where taking more doesn't raise that euphoric feeling. So it's a different effect than if you're taking fentanyl or heroin. We know that methadone, which has a much longer lasting euphoric feeling than heroin, is probably a really good transition drug to go to directly to start with. And this is also a good way of monitoring people as they take that first step and giving them the ability to break free from the control that they're under with heroin and with fentanyl. So yes, we're replacing one drug for another, and there are reasons why we're doing so.
Thank you. Susie, anything?
I have nothing to
All
add.
right. Thank you all. So traditionally, there was a philosophy that there is no level of safe use for someone with a substance use disorder, and that the act of return to use of any kind was deemed a relapse. Do you believe someone can limit their use to a safe amount? Why or why not?
I believe they can limit the use. With harm reduction, someone's going to get it. And it might be, you know, in the company of, like, the staff that we have at our job. It might click then. I've seen a lot of times where someone would tell me, hey, Carlos, look, I'm down to a bag a day. They're still using. I'm okay with that. I'm okay if tomorrow you just go down maybe a bag. I'm okay with that. What I'm not okay is leaving someone to die down there.
We did a study in 2003 with 20 black drug users, African American drug users. They came in and they gave this lady some information that she requested from them about their uses of drugs through the stages of change. Now, all these individuals had came all the way from 30 bags of heroin a day to gradually bring it down, 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 down. Now, this was a year-long study, right? At the end of the study, it was only 2 individuals that were ready to do something different. Some died, some got locked up, and others just continued their way. So there was an evidence right there that it can be done, and they were helped. I still see those 2 guys right now in recovery. They made it. I was 20. They don't have evidence.
Anyone else? Okay. Next question. How do you feel harm reduction has enhanced and or hindered the efforts to decrease the harmful effects associated with substance use disorders?
That's a loaded question. That's a dangerous question. You're going to get a lot of personal opinion with that question. It's probably why you asked it. But I'll try and attempt to answer that question. This is a personal viewpoint. It doesn't represent the agency I work for. Let me start with that, just to be clear. This is a personal viewpoint. When we're doing harm reduction work on a macro level, we know that needle exchange and providing resources lowers hepatitis. We know that it lowers HIV spreading in the population. We know that we get better overall health outcomes for people. But if you were to talk to the people that are getting the resources at times, one of their complaints is, you're just providing a needle for me to continue use, or you're just providing clean care, but you're not helping me break free from this addiction. And so from my personal standpoint, I want to be able to provide resources to people who are not ready to go into counseling or not ready to further their health. I want to be able to provide the tools that they need to stay as healthy as possible, and as Carlos says, to live another day. But I never want to be without the resources for the people that want to receive counseling and to even go for abstinence. I want to be able to make that available to them. And I think that we have a responsibility when we put ourselves in a position to help others, that we provide a complete way of care for them and not just leave them at a drop-off point. And so that's my belief on that subject.
Let me elaborate on that. I like to talk about the enhancement of it, right? I got an email the other day from a participant's mother. He got arrested, right? But before he got arrested, he had an opportunity to take a HIV test and hepatitis C test. HIV Hep C, right? Now, hepatitis C positive. He had an opportunity to get his medication sent to the jail. That enhanced his ability to fight off that infection, right? Now, I got another guy, he went back into treatment. He too needed a prescription. Had they not came to our program, or I went to their program and tested them, they would have went on with those infections, not knowing what was going on, sprayed them to everybody else. Now, this guy, I'm not calling his name, but he had an infection in the mouth. So he might be spreading that to somebody else unbeknown. He don't know what's going on. So it enhanced him to get some help and tell somebody else also, because now we want his partners also. Now they are aware, then they want their partners also. It goes on and on and on and on and on. It don't stop when somebody had an infection unbeknownst to them. So he's getting some help. It enhanced.
Thank you. So I'm going to ask the panel one more question for all of them to answer, and then I'll go to the audience. Starting with you, Susie, is there anything you would change or add to current harm reduction practices? And I don't know how different the practices are here in West Virginia, but generally speaking.
I think just being able to have something at every possible entry point, every point where you can encounter somebody, and that includes prevention, primary prevention, and teaching, working with our partners in primary prevention to teach them about, all the things that are encompassed in harm reduction. And everyone has, our whole initiative is called Be the One. And, we called it that so that, everyone would feel empowered and we would have a tool for everyone to be able to be the one to have some impact, to have some ability to affect change or to get people to consider, where they are in the process and whether, they're an ally and they participate in ally training. If they come and volunteer and get trained to do naloxone training, there's something there for everyone. So I think that the main thing I would change is that messaging, and that, because we went through a time period in West Virginia and we have a very restrictive legal situation around syringe service programs. And, so we've had to pivot around that. But, how can we get people to understand the full complement of what harm reduction is, that it's not just these particular things, but all the various entry points so that everybody has the opportunity to participate and be part of the solution.
Thank you. Adam?
There's not much to add to that. That was a good answer. I think, just reiterate what I said earlier, which is complete care when it comes to harm reduction. Don't stop halfway. Make sure that you have all the resources available for people, no matter what stage they are in their health and their pursuit of a healthy outcome.
Thank you. Edward? Anything to add? Okay.
I would just like to add client engagement as an individual. Know the backdrop of an individual. We need more education in regards to preventive services. If we're waiting for someone to get to that bottom of the bottom, then we're doing a disservice. Different parts of communities aren't ready for this type of language, but I think it's necessary. Thank you.
Thank you so much. And now I'd like to go to the audience. Can we get some mics right here? We have 3 right here in the front row for questions.
Thanks. Thank you, panel. I appreciate you so much. So my question is related to trust, buy-in, redlining in the Black community. So Edward, I think it's without question that you are the mayor of Highland Park, and I think Michael Simpson might be in that same category. Talk to us about the buy-in, right? Because you were integral to starting the CHR program. We already know that it takes the Black community. We have this really weird disconnect and deserved lack of trust for certain systems. Can you talk to us about how your relationship with Michael Simpson, who was a longtime small Black business owner in the city of Richmond? So let's talk about that.
Okay.
Your relationship with Mike, how you helped create this form of buy-in. You were able to go and talk to your friend.
Yeah.
Who in turn, his store is such a hub of Highland Park, and how that trust between the two of you, he was able to spill it over to create this buy-in, to create a space of trust. Can we talk about that? Because I got to tell you, if I was still in active use, I would not come to this program. It feels, it would feel like surveillance. So can you talk about the buy-in, that level of trust, and how y'all's relationship created this safer space?
Mike and myself, we go back maybe 50 years, right? We went to school together, as a matter of fact. And we played pool together. I beat him one time, he got mad. He been mad ever since. I beat him one time, right? And so I was going to the store, we kick it, we talk stuff. When I got hired at the Fan Free Clinic, I used to always go by his store and patronize him. And I said, Mike, is it okay if I stand right here and pass condoms out? He said, yeah, baby, what happened to stuff, man? So I'm helping the community with the condoms and stuff like that, but he wouldn't let me wear them in the store because he sold condoms, right? He told me that. You can't wear them in the store, baby. Well, you're taking money away from me. And so I set up a table outside, and that trust went on. Anytime there was an event, I said, Mike, can I come and set up a table? He said, yeah, come on, man. So I was able to set up and do HIV testing on the side of his store. Anytime something happened, I was welcome. The idea came up. about the harm reduction program, they asked me, did I know of a location? Of course I do. Went to Mike, I took Emily Westerham at that time to Michael Simpson. She said, do you think he's gonna let us do it? Yeah, why not? Let's go. I talked to Mike, introduced her. This is what we're trying to do, this is what we want to do. Mike, these are syringes that we passing out to people, harm reduction, right? Explain the whole program. He said, yeah, man, when y'all gonna start? Real simple, that was it. The buy-in was right there. And also, it helped him with his business also because more stores started opening up in that community and they were taking business away from him. So now it was a win-win for all of us. People coming, they go in the store, they gonna buy some items, stuff like that. And then also it's easy too because the bus come up and down, and Henrico County is right there, people coming to the city, going across town, it worked out well.
Thank you. And we have one online, and we have about 5 minutes left.
What suggestions do you have to get an organization that is against harm reduction to move toward or be more accepting of harm reduction?
I'll go first. They have to see results. You have to show them proof. There are times when folks aren't going to buy in, but you just have to give it time and be persistent in the work you do. There are communities that I go to, same thing. They're not real responsive to us bringing in harm reduction supplies in certain neck of the woods, but we keep at the fight. You know what I mean? We're persistent. We show up to events. We show up random pop-up Narcan trainings. They have to see firsthand that if someone is willing to go away to treatment, that we're available immediately. But in the meantime, let's help you reduce some of the risks with substance use behavior.
I think it starts with relationships. If you're going to bring in an organization or people that are hesitant to buy in, I think you have to engage with sincerity when you speak with them. I think you have to build trust so that they trust what they hear from you and what you say. I think that you need to be able to show them evidence to back the claims that you make. And then I think you need to be inclusive and to bring them in to the work that you do, no matter how small or what ways you do it, so that they can get actual experience and put eyes on the results and see the work. And all of a sudden, it's no longer a concept. It becomes a reality to them, and they have a fuller understanding. And I think if you apply those principles and build the relationship because of the work that you do and the good that it does, it's really hard at that point to kind of push off harm reduction or push it away or out of sight, just because it has such a beneficial impact on the community around you and them.
Thank you. And we have time for one more question. Can we get in the back?
Thank you. Really quickly, in communities that don't allow harm reduction syringe, has anybody come up with ideas or ways to get legislation to help get communities, government agencies, something like that? Law enforcement?
We are currently working on that at Prevention Point in Philadelphia. But that's hard. That's above my pay grade. In the meanwhile, what we do is we have mobile syringe services in areas in the city where we can get folks there and back. We manage with what we have. Those folks higher up, they are working diligently to get that stuff approved. But in the meantime, we're not giving up. We have mobile sites at various parts of the city on different days, and we have our exchange program at our building. So we see the need of it, and we just apply ourselves in any way we can, whether it's mobile or in-house.
All right, and I know as myself being a harm reduction enthusiast, there are more questions than there are answers, but we have to cut it right now. So can we all thank our panelists again? And if you still have questions, questions, if they're still around,
Sure.
you can talk to them after.